Hello, my name is Nathan Redmond from Syracuse University, and this is my research critique on the changes in OGTT-derived biomarkers in response to lifestyle interventions among Latino adolescents with obesity. And my mentor is Dr. Joon Kim. Now, there is an increasing interest in glucose concentration during an oral glucose tolerance test as biomarkers that differentiate type 2 diabetes risk among both the youth and adult populations. These biomarkers include the 1-hour glucose concentration, the shape of the glucose response curve, and the time to glucose peak. These biomarkers have been further characterized into high-risk and lower-risk phenotypes. The high-risk phenotype for a 1-hour glucose concentration is greater than or equal to 155 milligrams per deciliter, while the lower-risk phenotype is less than 155 milligrams per deciliter. The shape of the glucose response curve higher-risk phenotype is monophasic versus a lower-risk phenotype of biphasic. Time to glucose peak has a higher risk phenotype of late peak versus a early peak, which is considered a lower risk phenotype. Now, lifestyle interventions is the first line of approach to preventing type 2 diabetes and results in improvement in insulin sensitivity and beta cell function. However, there is no study that is examining the potential effects of showing the relationship between lifestyle interventions and OGTT phenotypes. Therefore, the purpose of this study was to test the effects of community-based lifestyle interventions on OGTT glucose phenotypes in Latino youth, and to explore if post-intervention changes in OGTT glucose phenotypes are differentiated by insulin sensitivity and beta cell function. Now, the present study was a secondary data analysis from a randomized controlled trial assessing the efficiency of a 12-week lifestyle intervention. The inclusion criteria for the participants in this study included being self-identifying as Latino, 14 to 16 years of age, and having obesity as defined by body mass index greater than or equal to the 95th percentile for their age and sex, or having a BMI greater than or equal to 30. The exclusion criteria included taking any medications or being diagnosed with any condition that may influence carbohydrate metabolism, physical activity, or cognition, having type 2 diabetes, being enrolled in a weight loss program in the past 6 months, or being diagnosed with depression or any other condition that may impact quality of life. A total of 48 participants met this criteria and were utilized in the study. The 12-week intervention included weekly nutrition education and 3 days per week of physical activity. The nutrition education classes were delivered by bilingual health educators to the youth and the parents and guardians, and specifically targeted reducing sugar-sweetened beverages and saturated fats in the diets, while emphasizing increasing in fruits, vegetables, and fiber in their diet. The physical activity sessions were delivered by certified trainers to the groups and designed to elicit an average heart rate of 150 beats per minute for each 60-minute session, and this was monitored through a heart rate monitor. Now, a 75 milligram oral glucose tolerance test was administered at the ASU Clinical Research Unit, which blood was collected at 0 minutes, 30 minutes, 60 minutes, 90 minutes, and 120 minutes. The OGTT glucose phenotypes of 1-hour glucose, time to glucose peak, and glucose response curve were then determined from this blood collection. Now, the results of this study, as shown in the figure above, indicate that there's a significant reduction in the prevalence of monophasic phenotypes with a p-value of 0.048, with a trend in reduction of the prevalence of 1-hour glucose greater than or equal to 155 milligrams per deciliter with a p-value of 0.054. This was following the lifestyle intervention. The prevalence of late peak phenotypes after the lifestyle intervention was reduced, although not significant, with a p-value of 0.201. As a whole, among the 48 participants, the intervention led to a significant increase in insulin sensitivity, as you can see in graph A, as it went from 1.7 to 2.1, and an increase in beta cell function, as you can see in graph B, as it went from 6.7 to 10. There's also a reduction, as you can see in graph C, from glucose AUC, as it went from 16,122 to 14,973. The differences in insulin sensitivity and beta cell function when compared to each OGTT glucose phenotype. Only the early peak glucose response phenotype showed significance by having a 35.3% or p-value of 0.023 greater insulin sensitivity. No other differences in insulin sensitivity or beta cell function were found after lifestyle intervention between the respective OGTT glucose phenotypes and the comparisons. as you can see in the graphs. So a comprehensive examination of type 2 diabetes risk biomarkers is essential for early identification of individuals at risk. And a 12-week community-based intervention has been shown to significantly improve insulin sensitivity and beta cell function, as well as higher risk OGTT glucose phenotypes of 1 hour glucose greater than or equal to 155 milligrams per deciliter and monophasic may be responsive to interventions in Latino obese youth. Previous studies among youth demonstrated that the 1 hour glucose concentration greater than or equal to 155 milligrams per deciliter and monophasic glucose response curve at baseline are prospectively associated with the worsening type of type 2 diabetes phenotypes and when compared to their healthier phenotype counterparts. The present investigation extends these findings and suggests that these phenotypes can improve among the higher risk youth in response to a lifestyle intervention. Now, with the growing number of Latino youth with type 2 diabetes and a heightened interest in early prevention against the ever-escalating disease, it is important to understand how lifestyle interventions can affect these biomarkers. However, there are some limitations in this study that can hinder the definitive conclusion on the relationship between lifestyle interventions, OGTT glucose phenotypes, insulin sensitivity, and beta cell function. The first being that there is a lack of available data on the physical activity each participant participated in throughout the intervention period. The study included the average heart rate during the 60-minute exercise period. However, the data could have been further explained through the use of an accelerometer and or breaking the groups into resistance and aerobic exercises by distinguishing which specific exercises may influence OGTT glucose phenotypes. Now, this would be out of scientific curiosity, but could provide important clinical and important public message that increased life, leisure, physical activity is linked to a favorable OGTT glucose phenotype. Additionally, the cutoff points for OGTT glucose phenotypes are arbitrary. Specifically, the criteria for defining increase or decrease in glucose value of 4.5 milligrams per deciliter was suggested based on a possible technical error or of glucose measures, not based on a physiological observation or suggestion. Hence, if an individual had an increase of 4.3 milligrams per deciliter, say, this would not be considered enough to be at peak, even though there was a rise. This can cause misrepresentation of the data. Lastly, the third critique is that the reproducibility of these OGTT glucose phenotypes could be potentially low. According to Kramer in their 2014 paper titled Changes in OGTT-Derived Biomarkers in Response to Lifestyle Intervention Among Latino Adolescents with Obesity, time to glucose peak was the only OGTT phenotype that displayed reproducibility on replicating tests. This means that 1 hour glucose and glucose response curve had poor reproducibility that should limit their utility. Hence, it's difficult to make a definitive conclusion on the responsiveness of the OGTT phenotypes as it relates to lifestyle intervention in the present study, as only one test was performed following the intervention. Thus, one suggestion would be to take multiple OGTT tests and average these phenotypes to ensure a more accurate representation of the data. I would like to thank my mentor, Dr. Joon Kim, my clinical research lab members, and Syracuse University, the Department of Exercise Science at Folk College. And that is the conclusion. Thank you.